Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. We have a YouTube channel where all the lectures are available. It is easily downloadable and you can see it at your leisure. We also have a Telegram group which you can join. It is very useful for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key by which you can navigate between the PDF and the YouTube. These are the disclaimers. We are with phase 3, which is recorded pathology lectures, which is very convenient for the teachers, students, as well as the organizers. And today we are with Pursue 1V, which is Uropathology, which is epithelial tumors of the prostate, Acinar Adenocarcinoma. And to talk on that, we have Dr. Mitadru De Sarkar, who's MBBS from JIPMER, MD from JIPMER. Presently is a consultant histopathologist at the Dr. Lal PathLab, Kolkata Reference Laboratory. He's also a consultant histologist as well as cytopathologist at Calcutta Heart Clinic and Hospital and an NABH accredited multispecialty hospital, and a consultant histopathologist at Wizderm PathLabs, a specialty dermatopathology laboratory. He has been an ex-assistant professor of the Department of Pathology at SMV Medical College and Hospital, and an ex-consultant pathologist at SRL Diagnostics, Fortis Hospital, Anandapur. Dr. Mitadru De Sarkar has authored a book which is on brain tumors pathology, which is very nice and very good book. It is available on Amazon. Also, you have a Kindle version of that. This is a flashpoint of that book. You can see Brain Tumor Pathology for Postgraduates, authored by Dr. Mitadru De Sarkar. Highly recommended book. With this, I would request Dr. Mitadru De Sarkar to start his lecture on epithelial tumors of the prostate, Acinar Adenocarcinoma. Over to you, Dr. Mitadru De Sarkar. Thank you so much.
Hello, and welcome to this discussion on the epithelial tumors of the prostate. This is the first part of the discussion, and we'll focus on Acinar Adenocarcinoma. So when we talk about Acinar Adenocarcinoma, we are basically we have to talk about three important scenarios. First, where we get the conventional Acinar Adenocarcinoma, the one that we most routinely see in clinical practice. Secondly, unusual histologic patterns, which can create some diagnostic confusion in the form of mucinous, atrophic, foamy gland, microcystic, and the pseudohyperplastic patterns. And lastly, the subtypes of prostatic Acinar adenocarcinoma, that is the signet ring cell like adenocarcinoma, sarcomatoid carcinoma, pleomorphic giant cell adenocarcinoma, and pin-like adenocarcinoma. The importance of the unusual histologic patterns is that although the diagnosis stays as conventional Acinar adenocarcinoma, because of the histology, you will sometimes be faced with a confusion with benign prostatic entities. While in the case of the subtypes, if you are sure that you have, you have ended up with a certain subtype, one of those four, you will have to basically label it as a Acinar adenocarcinoma of the variant subtype. You cannot call it a conventional Acinar adenocarcinoma anymore. So these are distinct tumor categories, that is the subtypes. So if you look at the CAP checklist, you'll see that the Acinar adenocarcinoma conventional or the usual form is highlighted at the top, while the other four types of Acinar adenocarcinoma subtypes, that is the signet ring-like cell, pleomorphic, giant cell, and the sarcomatoid and the prostatic intraepithelial neoplasia-like subtypes are listed separately. So in the first part of the discussion, that is in today's lecture, we shall be talking only about Acinar adenocarcinoma with the various subtypes. In the second discussion, we shall be talking about intrarectal carcinoma along with ductal adenocarcinoma and a few of the uncommon types of squamous and neuroendocrine cancers that can happen in the prostate. At the end of those two discussions, in the third part of the lecture, we shall be talking about the Gleason grading system, because proper idea of the Gleason grading system will need us to be aware of all the various histologies that you can expect in the case of a prostatic carcinoma. So we'll start off our discussion with Acinar adenocarcinoma of the prostate of the conventional or the usual histology. Talking a little bit about the genetic factors, you could have germline mutations or somatic alterations in multiple genes. Thus, you can have a germline mutation in BRCA1 and BRCA2 or in the ATM gene, which are associated with increased incidence of prostatic cancer. However, keep in mind that the family history of prostatic cancer will often be absent in such cases, even with the germline mutations. In the case of somatic alterations, you could have an activation of MYC overexpression. You could have a shortening of telomeres. You could have inactivation of the prostatic detoxification proteins like GSTP1, or you could also have inactivation of tumor suppressors like PTEN. This particular genetic fusion, this fusion like TMPRSS2 along with ERG is an important driving factor of prostatic carcinomas and can result in the overexpression of the ETS family of transcription factors, which is a very important oncogenic driver for the prostatic carcinoma. This particular this particular transcription factor is basically driven by the androgen mediated pathway, and sometimes in the case of an advanced prostatic Acinar carcinoma, even after medical castration, the patient can develop a prostatic carcinoma which is insensitive to the androgen deprivation. This is because in such cases, the androgen receptor gene can undergo amplification, mutation, or rearrangements. And lastly, decreased expression of NKX3.1, that is the normal homeobox gene in the case of the prostate, and CDKN1B, that is the tumor suppressor, can also be associated with Acinar carcinoma. Thus, you could have a loss of expression of GSTP1, NKX3.1, PTEN, or CDK1B, all of which are associated with the development of prostatic carcinoma. Or you could also have a overexpression of androgen receptor leading to prostatic Acinar carcinoma. So this entire family of proteins is involved in a sequential development of the prostatic carcinoma, going through the high-grade prostatic intraepithelial neoplasia to low-grade to the high-grade carcinoma category, and ultimately leading to a metastasis. But now let's get into the more interesting part of the discussion, which is the histology of prostatic Acinar carcinoma. Now, as you already know, the site of involvement is most often in the peripheral aspect of the prostate. And how do you identify those glands? The malignant glands in the case of a prostatic Acinar adenocarcinoma, firstly, will be small, round, tubular. They will lack the complex papillary infoldings that you have seen in the case of the benign glands. There will be only a single acinar cell layer and no expression and absence of the basal cells, which can further be highlighted by immunohistochemistry. And the cells will have a prominent enlarged nucleus with less voluminous cytoplasm and prominent nucleoli, which is an important diagnostic clue to identify these atypical malignant glands. Keep in mind that pleomorphism is usually not an important feature in the case of prostatic Acinar carcinomas. In fact, most of these cells are monomorphic in appearance, and so much so that in the case of a carcinoma of unknown primary, if you were to get adenocarcinoma like glands but not much of pleomorphism, you would think of prostatic Acinar carcinoma as one of the likely culprits. So this image towards the left shows you the malignant prostatic glands. As I've already said, these are small, round to angulated, tubular, lack the complex papillary infoldings, and have only a single layer of acinar cells, and there is a complete absence of the basal cell layer. And compare this to the image on the right, where you see a normal prostatic acini with the slightly papillary infoldings of the normal prostatic acinar cells, which are devoid of the prominent nucleoli that you see in the case of the malignant glands. And of course, you can also make out the presence of the basal cell layer at places. An important architecture by which we can basically isolate those atypical malignant glands is the creeping or the infiltrating pattern of those glands in between the normal prostatic acini. So if you see here towards the center of the image, you have these atypical irregular to tubular glands which is infiltrating through the stroma between the normal prostatic acini. As you can see, the cells, the glands are lined by a single layer of acinar cells, and there is complete absence of the basal cell layer. The cells also appear to have prominent nucleoli, the acinar cells. There is also a crystalloid in one of these atypical glands. And towards the upper and the lower part of the image, you have the normal prostatic acini. And if you use immunohistochemistry, as I have already said in our previous discussions, we have talked about P63, HMWCK, that is the clone 34 beta E12, and MAKER. You could utilize high molecular weight cytokeratins to sort out those malignant glands, although most of the times you will really not need immunohistochemistry. You can identify those glands by your naked eye. So in this particular case, you have again this infiltrating atypical acini infiltrating in between the normal prostatic acini. And as you see, the cells are just in a single monolayer of atypical acinar cells with prominent nucleoli. And high molecular weight immunostaining shows that the normal prostatic acini are having cytoplasmic expression of HMWCK, while the atypical infiltrating glands are devoid of HMWK expression. Sometimes you can have only 2 or 3 of these glands, of these suspicious glands, in a certain focus where you are not really confident as to whether you can straight away call it an Acinar carcinoma. Depending upon your level of confidence, you could call such foci as ASAP, that is atypical small acinar proliferation, or you could call it a minimal prostatic acinar adenocarcinoma if you are pretty sure that the nuclear and the overall architectural features appear to resemble malignant acini. So in this particular case, for example, you see these 2 acini which are distinctly atypical, because again there is no there is complete absence of the basal cells. The lining acinar cells are showing pretty much enlarged nuclei with very prominent nucleoli. So some would call it a minimal adenocarcinoma, well, some might still call it ASAP. So again, in the image towards the right, you have this irregular cluster of atypical infiltrating glands. Note that some of these glands have got slightly benign looking nuclear features, and the partial acinar atrophy comes as an important differential diagnosis in this particular case. So in such cases, obviously, you will need to use your either P63 or high molecular weight keratin, or sometimes a PIN4 cocktail. In this particular case, what they have utilized is a dual marker, which combines both P63 as well as high molecular weight keratin. This is actually much more sensitive than using individual P63 or 34 beta E12, because it tends to highlight the entire basal cell, that is both the cytoplasm as well as the nucleus. So if you see towards the right and the left, you have the normal prostatic acini, wherein the entire basal cell is basically outlined out. Both the nucleus as well as the cytoplasm is outlined out by the combination P63 and 34 beta E12 antibodies, while those atypical infiltrating acini between those normal glands are completely devoid of P63 and 34 beta E12 expression. So this is how the atypical glands look. And if you were to do a PIN4 cocktail, which again, most of us will not see in our routine practice simply because it's such a specific marker which is utilized only in a certain specific scenario, that it does not make much business sense if you are not dealing with a huge number of prostatic carcinoma cases on a daily basis. So, but it's it's an interesting slide to look at and appreciate, because it tends to tell you everything that is to be known about the malignant prostatic acini. So in this particular case, with the PIN4 cocktail, you see that the normal prostatic acini towards the upper right and the lower edges of the screen are showing complete expression of both P63 as well as high molecular weight keratin by the basal cell layers. The entire cell is blotched up in brown, while there is no expression of Amaker, while your atypical infiltrating malignant acini between those normal acini are completely devoid of both P63 as well as high molecular weight keratin and show coarse granular reddish positivity, because here it has been marked with fast red chromogen. So there's a coarse reddish positivity within the cytoplasm for Amaker. So this is how the PIN4 cocktail will look in your practice. So in this particular case, you have got this atypical infiltrating acini, malignant acini, which is completely devoid of P63 HMWCK expression and show coarse granular positivity for Amaker. On the other hand, your normal prostatic acini, which is seen scattered, are completely expressing the basal cell layer is completely expressing both P63 as well as HMWCK and is devoid of Amaker expression. A few acini over here could be those of the high-grade prostatic intraepithelial neoplasia, wherein there is some amount of Amaker expression, but at the same time, there is also patchily preserved basal cell layers seen towards the periphery. In our routine practice, more often we'll find ourselves dealing with individual markers. So you'll be probably ordering P63, HMWCK, and MKR separately when you are dealing with a case of a suspected prostatic acinar carcinoma. And in such cases, if you were to use MKR would give you this kind of positivity, a coarse brownish kind of cytoplasmic positivity. So these are the various markers which are utilized in the case of prostatic acinar carcinoma. Different markers will have different use scenarios. Thus, for example, if you are dealing with a prostatic carcinoma of unknown primary where you are suspecting prostate as the source, you would use NKX 3.1. In the past, it used to be PSA, but we know now that very poorly differentiated SNR carcinomas when they present as CUPs will not express PSA. So NKX 3.1 is always a better marker in this respect. It's also good because it's a nuclear marker and is easier to interpret. The other prostate-specific lineage markers are PSMA, prostate-specific membrane antigen, PROSTIN, or P501S, PAP. So all of these are of the cytoplasmic pattern of expression. MKR, like I've already said, if you are suspecting prostatic acinar carcinoma and you have got a benign non-neoplastic mimic as the differential, you will utilize MKR on top of your basal cell markers in order to isolate those malignant infiltrating acini. The positivity is, as I've already said, coarse granular cytoplasmic positivity, but keep in mind though that colorectal carcinoma can express MKR, and in cases where you have a differential diagnostic issue between a prostatic acinar adenocarcinoma and a colorectal carcinoma, just depending on MKR might not be a wise thing to do. P63 and HMWCK, like I've already said, they aid in diagnosis of prostate carcinoma by their negative expression, because the atypical acini do not have basal cell layers, so they will be negative for expression of both P63 as well as high molecular weight keratins. ERG sometimes can be utilized if you have got a atypical looking, malignant looking acinus, and if MKR is not helping you much, then you can probably add ERG to your panel. And in some of the cases, ERG will tend to be positive, in which case you could utilize ERG as an additional marker to lay claim to the fact that this is a prostatic acinar carcinoma that you're dealing with. Androgen receptor can also be sometimes utilized in this context. So this is how the atypical malignant acini will look. I've already gone over the features by which you will spot those glands and you will label them as a acinar carcinoma. These are some of the other findings that will help you to establish the fact that it's a acinar adenocarcinoma. So if you have perineural, that is the circumferential perineural invasion. You have various types of circumferential perineural invasion with the nerves mostly caught in transverse section over here. But again, sometimes they would be caught in longitudinal section as well. And if you get lymphovascular invasion proper, that also will classify as, that will also qualify as a diagnostic clue for acinar adenocarcinoma. These are some of the soft findings that you get in those atypical glands. Presence of the blue tinged mucin within the lumen of some of those glands is an important diagnostic clue, like you see in this particular image, where you have these atypical infiltrating prostatic acini, malignant acini, you have these interluminal bluish secretions. Observe that at some places, these bluish secretions have got organized into collagenous deposits, forming collagenous micronodules. So presence of collagenous micronodules is also an important diagnostic clue. Some of those malignant glands will show interluminal crystalloids, which is again an important aid to diagnosis. So interluminal crystalloids, collagenous micronodules, extraprostatic extension, perineural invasion, all of these are important diagnostic clues to identify a prostatic acinar carcinoma. And sometimes within the dilated malignant acini, you can get small protrusions, small glomeruloid-like protrusions of the malignant acinar cells. So this presence of these glomerulations is again another important diagnostic clue. So this particular slide shows you quite a few of the important features that we see in the case of the malignant acini. So you have got this haphazardly infiltrating pattern of infiltrating tubular, irregular, atypical glands, some of which have got the mucoid material, myxoid material in the lumen. Okay, if you are having crystalloids also, you have perineural invasion towards the left. And at some places, you are seeing that the mucin is getting organized into rounded nodular-like structures, forming collagenous micronodules. So in order to differentiate between the benign prostatic acini and the malignant glands of adenocarcinoma, these are some of the findings that we take into consideration as a group. First of all, the glands will be small, rounded, and crowded together. You will not get the basal cell layer, which you will further establish by immunohistochemistry. The cells will have very prominent nucleus. At the same time, nucleolus will also be very enlarged, often giving rise to a cherry red eosinophilic appearance. Perineural, lymphovascular, and extraprostatic extension are all important differential diagnostic clues in order to sort out those malignant glands. Collagenous micronodules, blue mucin, interluminal crystalloids, glomerulations are also important diagnostic features of malignant glands. And lastly, AMACAR expression, along with the absence of basal cell marker expression, will further add on to the differential diagnostic points. Now, coming to the various architectural patterns in which these atypical glands can be dispersed, you can basically differentiate those atypical glands into pattern 3, pattern 4, and pattern 5. In this particular discussion, we shall only limit our talk to the various architectural patterns in which you can see those glands oriented. Once you are thorough with the various patterns, you will basically utilize that skill in order to sort out the areas of a higher grade versus a lower grade, and then utilize that further in order to sum it up and get your Gleason score, and finally the grade group to which that prostatic carcinoma belongs. But that actually belongs to the realm of the Gleason grading system, which we shall talk about in a subsequent discussion. Over here, we shall only look at how the various patterns look in the case of a conventional prostatic acinar carcinoma, because oftentimes you will not get the very characteristic rounded tubular glands that we have already seen. Okay, so the glands will get fused, they'll get mixed up, they'll form cribriform architecture, they'll form solid sheets. So you need to be able to identify all of them in order to give a name to the particular pattern of orientation of those glands. So this is the lowest pattern that you see in the case of prostatic acinar carcinoma. Here you can make out well-spaced, rounded tubular glands. At some places, they look to be back to back, but at the same time, you can see that there is a thin rim of basement membrane-like material dividing the individual glands, and you can draw a line around individual glands. So this is not really a truly cribriform pattern. So this pattern wherein you have distinct glands separate from the other malignant neighbors and not really arranged in a cribriform fashion is what is known as the pattern 3. So as I've already said, sometimes they can appear to be closely coalescent, but again, the fact that you can draw a line around individual glands, thus segregating it from its neighbor, still qualifies that particular tumor as a Gleason pattern 3. Like in this particular case, these are the benign prostatic acini, which are seen towards the center of the field, but towards the left, there is a slightly crowded focus. So whenever you see a degree of glandular overcrowding in a prostatic needle biopsy, be careful, look into those glands at a higher power, and appreciate the fact that there is probably no basal cell layer to talk of, and the cells are having prominent nucleolus, the acinar cells, that is. So if you look into these acini at a higher power, you will see that these acini are lined only by a single layer of acinar cells. There is no basal cell layer to speak of, and quite a few of them are having prominent nucleoli. So these qualify as pattern 3 glands, because again, you can sort out one gland from the other, and it's not really forming a cribriform mazework. Again, over here towards the right and the left of the screen, you have got the benign prostatic acini, and infiltrating into the stroma in between these benign prostatic acini, you have got these haphazardly oriented, rounded to tubular glands, which are completely devoid of the papillary enfoldings that you see in the case of the benign glands. At some places, they appear to be coalescent, but again, you can make out individual glands. So it's not a higher pattern. It's still the pattern 3 of prostatic acinar carcinoma. So these are the atypical glands which are completely devoid of the basal cell layer. You just have a single layer of acinar cells which have prominent nucleoli. Even at this power, you can appreciate the nucleolar prominence in quite a few of these cells. Now, Gleason pattern 3 is what you see towards the right. Towards the left, actually, you have got a Gleason pattern 5. I shall talk about that later, but let's just talk about, don't look at this dirty pinkish material towards the center of the lumen. Rather, appreciate the fact that these glands are aggregated together into a complex mass wherein you cannot really sort out one gland from its neighbor, and you have got these rounded cribriform spaces which are punched into this mass of cells. So that pattern of cribriform architecture is what qualifies as pattern 4. But I shall go one step ahead and actually call this pattern 5. Why? Because you have this, you have got this dirty necrotic cometonecrosis like appearance within the cribriform space, and whenever you get necrotic debris within the cribriform lumen, it actually qualifies as Gleason pattern 5. So although I have leveled it out as Gleason pattern 4 because of the cribriform architecture, because of the presence of the necrotic debris, I have to go one step higher and call it a pattern 5. But this is how the usual pattern 4 will look once you get a needle biopsy. So for example, over here, what you see is a complex fused mass of cells which are growing in sheets. But again, within the sheets, you have this cribriform, whitish, rounded, glandular luminal-like spaces punctuating the entire sheet-like architecture. So this is the complex coalescent cribriform mass of cells which gives it a Gleason pattern of 4. Okay, so you have these cribriform luminal spaces forming within this mass of cells. That cribriform pattern is one of the patterns that you see in the case of pattern 4. Another pattern that you see in pattern 4 is the ill-formed glands. So if you compare the Gleason pattern 3 glands towards the left, where you get proper individual, well differentiated atypical glands that we have talked of in the initial part of our discussion, the image towards the right shows something different. Although you have got a few atypical glands, which are the round to tubular angulated glands that you see in the case of pattern 3, quite a few of these glands are giving you a vague idea of a glandular differentiation without a proper lumen or without a proper architectural orientation of the cells in the form of a tubular structure. So these kind of haphazardly infiltrating glands, which give an idea that they are probably glands, but not very well formed glands that you see in the case of pattern 3, are called as pattern 4 glands. So these are of a higher grade than the pattern 3 glands. So the cribriform architecture as well as the ill-formed glandular pattern both qualify as Gleason pattern 4. So over here in this case, you see this complex cribriform mass of cells forming cribriform spaces. So this is basically pattern 4, but at the same time, towards the upper aspect of the screen, you have some areas which appear to be forming gland-like spaces, but not a proper gland. So there are ill-formed glands as well. So you have a mixture of the cribriform architecture along with the ill-formed glandular architecture, and both of them would actually qualify as a pattern 4. So this is a pattern 4 Acinar Adenocarcinoma that we are seeing. In this particular case, we have got the benign prostatic acini towards the center and towards the left half of the screen, although a few of them are actually having high-grade prostatic intraepithelial neoplasia-like features, wherein you see the slightly tufted architecture and the cribriform architecture within those dilated acini. But let's turn our attention to this fused mass of glands towards the bottom of the screen. So if you see over here, again, you have got a few atypical acini which are joined together to form a cribriform mazework. So this is again a Gleason pattern 4. As I've already said, within the cribriform mazework of cells, if you were to get dirty necrotic luminal debris of a cometonecrosis like pattern, although it has a cribriform architecture, it will not be called a pattern 4. Because of the presence of necrosis, you will call it a pattern 5. So presence of necrosis within the cribriform spaces qualifies the tumor as a Gleason pattern 5. So basically, it follows to logic that the higher pattern that you have, the more aggressive histology you are dealing with. Again, another architecture in the case of pattern 5 is where you just have a solid mass that is a sheet-like architecture of the cells without any acinars structure within those sheets. Even the cribriform spaces that we saw in the case of the pattern 4 are lacking in the case of a pattern 5. So it's just a solid mass of cells. So in this case, where you see a solid sheet-like mass of cells infiltrating into the periprostatic fat. A third pattern that you see in the case of the Gleason pattern 5 is where the proper lumen of the atypical glands is not seen at all. Rather, you see those cells which are arranged in the form of a trabecular or a single line fashion. So this particular kind of architecture also qualifies as a Gleason pattern 5, obviously an aggressive pattern. So summing up all these things together, if you have discrete atypical glands infiltrating between the normal acini, you will call it a pattern 3. Some back-to-back glands are allowed, but you will have to be able to sort out individual glands in this back-to-back architecture, and they will still qualify as pattern 3. On the other hand, if you have fused microacinar glands wherein you cannot really segregate one gland from its neighbor, and rather you have just these round luminal spaces within this cribriform meshwork, is what qualifies as the cribriform glands of pattern 4. Although even the ill-defined glands with poorly formed lumina will also qualify as pattern 4. Sometimes the cells will have a very clear cell RCC-like morphology known as the hypernephromatous pattern, and that is also a pattern 4 architecture. In the case of pattern 5, you will have essentially no glandular differentiation, only solid sheets, sometimes cords or single cells. Presence of comedocarbcinoma with central necrosis will also qualify as pattern 5. Now, if you look at the upper half of the screen, you'll see that I have basically I have crossed out the pattern 1 and pattern 2 because these are two patterns that you will never diagnose in the case of a needle biopsy. Most of these actually turn out to be a non-neoplastic mimic of carcinoma known as adenosis. So keep that in mind, that whenever needle biopsies are concerned, you will be mostly dealing with pattern 3, pattern 4, and pattern 5 atypical glands. Now, coming to the various unusual histological patterns of Acinar adenocarcinoma of prostate, keep in mind that these unusual patterns will not change your diagnosis from a conventional Acinar adenocarcinoma. Your diagnosis will still be Acinar usual adenocarcinoma of the prostate. The important thing about these patterns is that because they tend to mimic non-neoplastic entities, you will have to have a high index of suspicion in order to pick out those atypical glands with not so much atypical features. So in this particular case, the various unusual patterns include mucinous pattern, atrophic pattern, foamy gland pattern, microcystic pattern, and the pseudohyperplastic patterns. We shall be seeing each and every pattern separately with a couple of examples of each. So in the case of mucinous or the colloid carcinoma, basically as the name suggests, mucin accounts for a huge proportion of the tumor. By definition, it has to account for more than 25% of the tumor volume, which is one reason why you will probably never make the diagnosis on a needle biopsy. In a case of a needle biopsy, you will probably sign it out as a prostatic adenocarcinoma or a prostatic acinar adenocarcinoma with mucinous features, because in order to appreciate the entire tumor volume, obviously you have to deal with the radical prostatectomy specimen. Another thing to be kept in mind is that we should not get disoriented by all that mucin which is present in the background. As far as the Gleason scoring and grading of that particular tumor goes, you should only look at the glands which are scattered in the mucinous background. You have to look at the architecture, and you have to utilize the same points which I've already talked about as far as differentiating pattern 3, pattern 4, and pattern 5 goes. You will utilize the same diagnostic features in order to give a final Gleason grade to the mucinous carcinoma. And of course, because there is abundant mucin, you will also often tend to have collagenous micronodules. And one important thing to be kept in mind is that the cells are often monotonous and bland looking, and although bland and monotonous, nucleoli is often prominent. So that presence of the nucleolus is a very important diagnostic clue, which will help you not only to identify the variant patterns of prostatic acinar carcinoma, even in the case of the subtypes of prostatic acinar carcinoma, the presence of prominent nucleoli is an important diagnostic aid. What about the immunoprofile? It's the same as that of a conventional acinar carcinoma. So expect positivity for PSA, PSMA, NKX 3.1, etc. Basal cell markers will be absent in those acini. MKR expression can be, however, variable. So when I mean mucin, the background will look somewhat like this. It will give you a pale whitish to slightly bluish myxoid look. And within that, you will have this atypical acini dispersed in various configurations. Like, for example, in the image towards the left, you see them forming a cribriform meshwork. So that's a pattern 4. While on the image towards the right, you have individual discrete glands which are freely floating in the mucin. So that's a pattern 3. So the most important thing about this mucinous of the colloid carcinoma is that the metastatic colloid carcinoma or the mucinous carcinoma from the colorectum is a very important differential diagnosis. Over there, immunohistochemistry is of a lot of use, because in the case of prostatic metastatic colloid carcinoma from the colorectum, CK7 and CK20 will show variable degrees of expression. Often CK20 will be positive and CEA will also be expressed. SATB2 is an important marker which is utilized in this context because it will not be expressed in the prostate and will be expressed in colorectal carcinoma. Again, the prostate specific antigens will be absent in the case of in the case of metastatic colorectal carcinoma. Keep in mind that CDX2, which is a slightly old school marker as far as the colorectal carcinomas is concerned, can also be expressed as in mucinous prostate carcinoma. So don't rely entirely on CDX2. Now, this is an important diagnostic feature that we are, that we are well aware of, that in all organs where you have a mucinous carcinoma, CDX2 can sometimes lead to confusion. We also know that in the case of the ovarian mucinous carcinomas. Now, coming to the Gleason grading and the clinical significance, like I've already said, for mucinous carcinomas, Gleason grading should be only based on the architecture of the atypical Acinar component and utilize the same diagnostic clues for identification of pattern 3 versus pattern 4 versus pattern 5. Also keep in mind that pure colloid carcinoma is rare. Most of the time, what you will end up is with a conventional prostatic Acinar carcinoma where you have a lot of background mucin, that is with presence of mucinous features. Coming to the pseudohyperplastic carcinoma, now I've already said that in the case of carcinoma, the malignant glands of prostatic Acinar carcinoma are usually round, tubular, and lack the complex papillary infoldings that you see in the case of a hyperplastic prostate or in the case of a benign prostate. However, this particular, this particular histologic appearance has got the papillary infoldings as well. So, thus giving rise to a differential diagnostic issue with benign prostatic hyperplasia. So this particular pattern needs to be kept in the back of your mind, that sometimes prostatic adenocarcinoma Acinar can look like a BHP. However, an important diagnostic clue, as I've already said, in most of the subtypes as well as in the variants are the prominent nucleoli. So you will get the lining Acinar cells with prominent nucleoli. You will have an absence of basal cells. And most of the times, this will be given a Gleason score of 3 + 3 = 6. And as I've already said before, look around for conventional Acinar adenocarcinoma mixed up with those pseudohyperplastic glands. Oftentimes, you will find that. However, having said that, in core biopsies, sometimes you may not be able to find the characteristic classic Acinar adenocarcinoma like tubular glands. So in such cases, you need to be aware of this particular variant histology and appreciate the fact that the cells lining those pseudohyperplastic glands have got prominent nucleoli. There is no basal cells, and you will also utilize basal cell markers in order to establish that fact. Amaker, again, don't entirely depend on Amaker because it is variably expressed and has got an overall low sensitivity as far as the pseudohyperplastic carcinoma is concerned. So over here in this particular case, you have some of these glands where you have slightly micropapillary like infoldings of the lining epithelial cells, although towards the right you have got a conventional Acinar adenocarcinoma element. Towards the left, some of those suspicious looking glands are not really looking like the conventional Acinar adenocarcinoma. If you look into these glands at a higher power, you see that there is a lining, or there is a single lining of the Acinar cells over here, although at places it looks like that there is a basal cell layer. It's most likely the compressed fibroblastic, myofibroblastic cells of the stroma which are present towards the periphery. If you look into these cells at a higher power, you will appreciate that quite a few of them have got prominent nucleoli. So presence of the nucleoli is an important diagnostic clue in these cells. Okay, these are not usually present in the case of a normal benign hyperplasia of the prostate. This is another case where you have this compacted mass. So this kind of compaction or the closely spaced appearance of these glands is also an important clue that you could be probably dealing with a Acinar adenocarcinoma. The cells again have got kind of voluminous cytoplasm. They form slightly outpouched architecture focally within some of the dilated acini. And appreciate the fact that there is just a single layer of cells lining these cells. These cells are of the Acinar type, and there is no basal cell layer. If you look into these cells at a higher power, you can again appreciate the prominent nucleoli in a few of these cells. Again, in this particular case, you have got this single layer of acinar epithelial cells. Look at the look at the left hand side. There appear to be a basal cell layer, but this is actually the acinar cell layer which is caught in tangential section. So it gives you an impression as if there are there is a two cell layer, but these are actually only a single acinar layer. So of course, you will use high molecular weight keratin if you have it and establish the fact that there is no basal cell layer in these pseudohyperplastic glands. The differential diagnosis, of course, in this particular case becomes benign prostatic hyperplasia. The fact that there is no basal cell layer, that the cells lining the acini have got prominent nucleoli, and the fact that these are oftentimes associated with conventional acinar adenocarcinoma glands will help you to establish a diagnosis of the pseudohyperplastic pattern. However, as I've already said, because in the case of a needle biopsy, oftentimes you will get only those pseudohyperplastic glands. If you do not have markers, then it's probably better to call those glands just ASAP and advise it for HMWCK, P63 and MIKEY in order to be sure. Coming to the foamy gland appearance, that is the foamy gland pattern, you have basically those atypical glands with abundant foamy, almost a xanthomatous kind of a cytoplasm. Another important feature of those glands is that the cells lining those glands have got very hyperchromatic, small, dense nuclei, and sometimes appreciation of that prominent nucleoli, which is a very important diagnostic clue, may not work out well in the case of a foamy gland pattern. Okay, so and most of these foamy gland types are actually of a low grade, that is of the Gleason score 6 or 7, although sometimes they can have 8 to 10 scores as well. Basal cell markers, as expected, will be negative in those acini, and MIKEY again is variably expressed. In cases where MIKEY is not expressed, you could probably use ERG, and if ERG overexpression is present in the acinar cells, you could still label it as a Acinar carcinoma. So again, an important point over here is that the very closely compacted nature of the glands, which raises suspicion. However, the cells have got abundant voluminous amount of cytoplasm, as you see over here, almost of a pale, foamy kind of a nature. Also appreciate the fact that many of these glands are having lining acinar cells, which are very, very hyperchromatic, small, round, and dense. And appreciating nucleolus within such cells is very, very difficult. Although if you look into these cells at a higher power, you will see that along with these hyperchromatic cells, you have a smattering of cells which are showing prominent nucleolus within them. So that's the diagnostic clue. Okay, so in this particular case, for example, you just have a complex coalescent mass of these tubular glands with abundant foamy vacuolated cytoplasm, very uniformly hyperchromatic small round nuclei where appreciation of nucleolus is difficult. Such cases will obviously need you to utilize those high molecular weight keratins, P63 and MIKEY in order to establish a diagnosis. Like in this particular case, again, observe the image C, where the nuclear features are pretty bland, although the cells have got the characteristic foamy vacuolated kind of a morphology. So if you use high molecular weight keratin, you see that there is a complete lack of expression of basal cells within these atypical acini. So the differential diagnosis in such cases becomes Cowper's glands, which also can be sometimes present as a part of the normal histology. They also contain mucin within their cytoplasm. However, they have got a lobular architecture, and sometimes a foamy xanthomatous macrophage-rich inflammation can mimic this particular histology, although you don't get glands in such cases. They will be mostly organized in the form of a solid mass. But if in confusion, you can always use macrophage markers like CD68 or CD163 along with pan-CK in order to sort out the carcinoma from the xanthomatous inflammation. Now coming to atrophic pattern, the atrophic pattern is an important pattern because oftentimes the glands are so small and innocuous looking that you will miss out on the fact that they are atypical malignant glands. So again, what are the important features which help you suspect that this is probably an atrophic adenocarcinoma and just not a purely benign atrophic gland? Appreciate the fact that there is prominent nucleoli within these acinar cells. That's an important point again. And again, basal cell layer will be absent in these glands, but sometimes in the case of a atrophic, normal benign atrophic glands, appreciation of the basal cell layer might be problematic there as well. And also, as I've already said, in all these variant histotypes, always look for conventional acinar adenocarcinoma of a non-atrophic pattern. Usually they'll be present in the background, and that will further add to your diagnostic certainty. Another important fact to be always remembered is that whenever you have an acinar adenocarcinoma with atrophic features, especially if you are dealing with a larger specimen, be aware whether the patient has got an androgen ablation treatment or radiotherapy prior to that, because even in such cases you can have atrophic changes within the malignant glands, but you would not call it an atrophic adenocarcinoma. So as expected, basal cell markers will be negative in such cases. MKR will be variably expressed, and although they can be negative in 30% of the cases. Another important diagnostic pitfall is that some of these atrophic carcinomas can actually show an aberrant positivity for P63. Now that becomes problematic because, as we know, P63 expression is a sign that probably basal cell layer is preserved. So P63 expression actually adds on to the diagnostic confusion, and you start wondering whether this is just atrophic gland with a preserved basal cell layer. In that case, keep in mind that although these atrophic glands are expressing P63, they will not express high molecular weight keratin. So that's an important diagnostic clue. And you can also use ERG in these cases, because ERG positivity will aid in establishing the diagnosis that it's a atrophic adenocarcinoma with P63 positivity. However, lack of ERG positivity does not exclude the diagnosis. So in this particular case, if you see, there are quite a few glands where the lining acinar cells do not have any cytoplasm at all. They look atrophic in nature. And if you look within these glands, you will have to appreciate the fact that although they have less amount of cytoplasm, the cells which are lining these atrophic looking glands have got prominent nucleoli, which can be appreciated at a higher power. So this is the atrophic pattern of conventional prostatic acinar adenocarcinoma. Also appreciate the fact that they are usually mixed up with the normal conventional prostatic adenocarcinoma glands. Okay, so you have got the conventional prostatic adenocarcinoma as well mixed up with these atrophic pattern glands. So the presence of nucleolus, prominent nucleolus in those lining acinar cells is an important diagnostic clue. Again, over here, you have got the benign prostatic acini towards the bottom of the screen, but again, you have got these infiltrating atypical glands, which have got very scanty cytoplasm, almost looking like atrophic glands. But if you look at those glands at a higher power, you will see that the cells lining them have got prominent nucleoli. So again, it's an atrophic pattern of conventional acinar adenocarcinoma. Look at that. Look at these atrophic glands, which are marked out with the arrow. Okay, so you have atrophic glands, but at the same time, you also have conventional acinar adenocarcinoma-like glands mixed up with those atrophic glands. And if you look at those glands from the point of view of a pin-4 cocktail, things become very interesting. So you have got the normal prostatic acini, which show basal layer expression of both high molecular weight keratin along with P63, no expression of MKR at all. At the same time, the conventional prostatic acinar adenocarcinoma shows a complete lack of expression of the basal cell markers with positivity for MKR. And even those atrophic pattern glands are showing basal cell marker absence along with a positive expression of MKR. So the differential diagnosis, it basically becomes the simple atrophy, post-atrophic hyperplasia, and partial atrophy. These are all benign entities which should be segregated from the atrophic pattern of the prostatic acinar endocarcinoma. One important clue is that many of those cases are actually lobulated and they do not have that infiltrating architecture. At the same time, the amount of atrophy in those cases of non-neoplastic atrophy is actually much more, so that the cells look very dark and basophilic. While in the case of atrophic carcinoma, they usually have some amount of cytoplasm, so they do not have as basophilic a hue as the non-neoplastic atrophic cases have. And of course, you will also have to appreciate the prominent nucleolus in the case of the atrophic pattern adenocarcinoma. And also appreciate that oftentimes they will be mixed up with non-atrophic conventional prostatic carcinoma. P63 positive prostatic adenocarcinoma, as I have already said, is just a certain subgroup within this category of atrophic pattern adenocarcinomas, which aberrantly express P63, thus leading to a diagnostic confusion with the atrophic glands, benign atrophic glands. Keep in mind that although they express P63, they will not express high molecular weight keratin. So if you use a dual cocktail of HMWCK with P63, things become interesting, as we shall see in another slide. And they are usually positive for MKR, which is again another good thing. So the pin for cocktail becomes very useful in this particular scenario. Like for example, over here in the image towards the left, there is no confusion that you are probably dealing with a pattern 4 plus a pattern 5 Acinar carcinoma with atrophic features because the amount of cytoplasm is very scanty. However, if you were to do just P63 on such cases, things would become confusing because all these cells would show nuclear positivity for P63. That is aberrant nuclear expression. But if you use a pin-4 cocktail, things become very interesting because the normal prostatic acini show a complete positivity, both nuclear and cytoplasmic within the basal cell layer, and no expression of MKR at all. So it's very easy to sort out the normal glands. At the same time, if you look within those atypical infiltrating glands, one important feature arises. You see the nucleus, which is highlighted out by brown, meaning that P63 is expressed. But at the same time, you cannot appreciate the cytoplasmic positivity, meaning that there is a lack of expression of high molecular weight keratin, which is an important diagnostic clue as far as the acinar adenocarcinoma is concerned. Also, the fact that there is a patchy expression of MKR within these glands helps you to further establish the fact that you are probably dealing with a P63 positive atrophic patterned acinar adenocarcinoma. Coming to the microcystic pattern of adenocarcinoma, of the acinar adenocarcinoma, basically the glands over there oftentimes are atrophic, but at the same time they're very cystically dilated to the point they're on average usually 10 times the size of the normal prostatic acini. And the cells which line them are again atypical with prominent nucleolus, and oftentimes there will be a mixture of smaller acinar adenocarcinoma glands along with. So that's the diagnostic clue. These are usually assigned a Gleason pattern 3. Basal cell markers will be negative and MKR will be expressed in 96% of the cases. So as you see, there are the infiltrating atypical prostatic acinar glands, but at the same time, you also have these very large cystically dilated acini, grotesquely enlarged in size, at the same time lined only by a single layer of atypical acinar cells, no basal cell layer to speak of. And this monolayer lining of acinar cells all have prominent nucleoli. So that's an important diagnostic clue. And of course, if you do high molecular weight cytokeratin, you will appreciate the fact that the normal atrophic acini are expressing high molecular weight keratin, while those large cystically dilated glands are not showing expression of basal cell marker. And if you do a P63 MKR cocktail within such malignant acini, things become again very interesting because the normal atrophic acini towards the left are showing nuclear positivity for P63 in the basal cells, but the atypical large cystically dilated acini are showing only cytoplasmic MKR expression and no expression of P63. So the differential diagnosis in such cases is cystic hyperplasia and cystic atrophy. Utilize all those features that I've talked about: absence of basal cells, prominent nucleolus, MKR expression, lack of basal cell markers, and adjacent small component of the usual conventional acinar adenocarcinoma in order to establish the diagnosis. Coming to the last part of the discussion, that is the various subtypes of acinar adenocarcinoma of the prostate. As I've already said, if you are pretty sure that you are dealing with these categories, you will not call it a conventional acinar adenocarcinoma. You will sign it out with the name of that particular subtype that you are seeing. Having said that, because in a prostatic needle biopsy, often things are very heterogeneous, we will probably only be raising the suspicion of this particular subtype because we are not seeing the lesion in its entirety. But it's important to know about these particular subtypes because they're very aggressive in nature. Many of them are actually of the pattern 5 by definition. And it's important to know about this subtypes in order to separate them out from the usual conventional acinar adenocarcinoma of a lower grade. Now coming to the signet ring cell-like adenocarcinoma, as the name suggests, it's all signet ring cells with the characteristic appearance with the peripherally displaced nucleus towards the periphery and the abundant clear cytoplasmic vacuole. These cells will be growing in mostly sheets and in small clusters as well as in dispersed single cell population. And as in the case of mucinous carcinoma, the signet ring component should be more than equal to, that is at least 25% of the tumor mass, which again means that in a case of a needle biopsy, you will probably not sign it out as a signet ring cell-like adenocarcinoma. You will call it a acinar adenocarcinoma with signet ring features and mention the possibility of it being a signet ring cell-like adenocarcinoma as a note and advise the final evaluation based upon the radical prostatectomy specimen if it comes up. This will be variably positive for prostate-specific markers, meaning that you will probably have to use 2 or 3 markers in order to get that particular diagnosis of a malignant prostatic Acinar cell. NKX 3.1 is very useful in that context. And this, as in the case of a prostatic Acinar carcinoma, this will be negative for CK7, CK20, and HMW-CK expression, and will express mucin. So over here, you have got these atypical signet ring-like cells, which are dispersed in the form of solid sheets in between the normal non-neoplastic prostatic acini. Two important dictums apply to this particular subtype. First, in the case of a prostate, if you were to get an adenocarcinoma with signet ring features, always exclude a metastasis from some other organ, of which colorectum is a very important site. But at the same time, you could also have metastatic signet ring cells coming in from organs like stomach, lung, or the pancreaticobiliary tree. And the other important thing to be kept in mind is that if in some other organ you are dealing with a carcinoma of unknown primary, and if you come across atypical signet ring cells, and in a male patient, always keep prostate as a possibility of the source of the primary, and in which case you will probably need to add NKX 3.1 to your panel. Keep in mind that sometimes lymphocytes can have a whitish space around them and can give rise to pseudo signet ring features. In the case of sarcomatous carcinoma of the prostate, there are 3 individual histologies that fall into this particular subtype. The commonest one is where you have a sarcomatous element, but you have got scattered individual carcinoma cells which are dispersed in the form of glands or in the form of cribriform nests within the spindle cell population. So in such cases, it becomes easier to label it as a prostatic sarcomatous carcinoma because of the presence of this scattered minor atypical epithelial element. But sometimes you can have a purely monophasic spindle cell tumor, just as in the case of monophasic spindle in the case of synovial sarcoma, monophasic type, where you have a problem because there is no epithelial element to speak of. So over here, even you will have to take the recourse of immunohistochemistry and sometimes electron microscopy in order to even call it a carcinoma. And lastly, you can have also heterologous differentiation in the form of malignant osteoid or cartilaginous matrix within the tumoral component. The most of the sarcomatous carcinomas of the prostate are of a very high grade in nature, often of the pattern 5, and the carcinoma element, if it is present within the sarcomatoid component, will be positive for prostatic markers along with pan-CK, etc. And the spindle cells will at least show focal positivity for pan-CK, EMA, and paradoxically P63. So keep that in mind. So if you are having a larger specimen, you can use a generous dose of markers in order to arrive at your diagnosis, but otherwise you will definitely have to have pan-CK, CAM 5.2 along with 1 or 2 of those prostatic markers as a part of your panel. And in those cases where IHC is not turning out to be of much use, you can probably take the help of FISH in order to establish the presence of this particular TMP RSS2 ERG fusion that we talked about in the first slide, and that may be useful in order to confirm the tumor's prostatic origin in the case of a carcinoma of unknown primary. Like in this case, you have got a high-grade sarcomatous component, which is seen towards the left, but scattered within this sarcomatous element, you have got these atypical acini and cribriform nests of cells, which help you to establish the fact that this is probably a sarcomatous carcinoma subtype of prostatic acinar carcinoma. Here you have got heterologous differentiation in the form of malignant osteoid formation or malignant chondroid matrix. Again, in this particular case, with so much of conventional pattern 4 Acinar Adenocarcinoma mixed up with the sarcomatous element, it becomes easy to establish the diagnosis. Of course, we know that pan-CK, if it is done in such cases, will turn out to be positive within these atypical elements. Although note that a few of the these spindle cells may show patchy positivity for pan-CK as well, which is always useful as far as diagnosis is concerned. So if you use other prostate-specific markers like prostine, NKX 3.1, or PSMA, you will find that the atypical malignant epithelial component picks up positivity for those. ERG is also focally positive in some of these cells. Coming to the pleomorphic giant cell carcinoma subtype, as the name suggests, you'll get a lot of bizarre anaplastic, almost MFH-looking cells within the background. By definition, there should not be a spindle cell element, because sometimes in the case of sarcomatous carcinoma, you could get such anaplastic looking cells as well. These are highly aggressive and mostly classified as Gleason pattern 5. And again, many of these cases actually arise after prior history of androgen deprivation. And however, the cells will be usually strongly positive for PAN-CK or CAM 5.2. So that's of diagnostic aid. And most of these cases will at least focally express one or more of the prostate restricted markers. P10 loss, TP53, this P53 mutations can also be seen in such cases. So over here, as you see, you get these pleomorphic, atypical, highly anaplastic looking, almost MFH looking cells in the background. As you can see, PSA shows a nice positivity within those atypical cells. MACR is also being expressed, and so is PSMA. The differential diagnosis in such cases obviously is the pleomorphic urothelial carcinoma, because that is a very important mimic when you get an anaplastic carcinoma, anaplastic looking carcinoma in the prostate. Thankfully, IHC is of a lot of assistance in such cases, because you get almost exactly the opposite immunoprofile in the case of urothelial carcinoma. You have expression of high molecular weight keratins and P63, which is not seen in the case of prostatic carcinoma. You have CK5-6 usually, and you often have a dual positivity for CK7, CK20, while in the case of prostatic acinar carcinomas, it's usually a dual CK7-20 negative immunoprofile. GATA3 expression is also very useful in order to identify the urothelial source of the origin. And as I've already said, sarcomatoid carcinoma can sometimes have neoplastic giant cells, so that also should be kept as a differential if you have got a sarcomatoid element to the tumor. The last subtype, and the very important subtype which has recently come up, is the pin-like subtype, that is the prostatic intraepithelial neoplasia-like subtype of Acinar Adenocarcinoma. The glands over here look more like AGPIN rather than a prostatic acinar glands, as in you will have slightly dilated acinar spaces where the cells form a pseudostratified tufted kind of a growth that you see in the case of a tufting pattern of AGPIN. However, if you were to get a cribriform or a papillary growth pattern within those acini, you would probably start thinking of a prostatic ductal adenocarcinoma. So presence of cribriform or papillary growth within such glands would be actually incompatible with the diagnosis of pin-like adenocarcinoma. Sometimes these glands can be very cystically dilated and can come out in strips. So you will see only probably a part of the wall of these glands. And oftentimes you will have a component of acinar or a ductal adenocarcinoma mixed up with those glands. Significant nuclear enlargement hyperchromasia are usually present in those glands, but most importantly, nucleolus that we have basically talked about in almost all the variants will often not be prominent in this particular subtype. In fact, HGPIN glands will sometimes have much more prominent nuclei, compared to these glands of the pin-like adenocarcinoma. However, thankfully, basal cell markers will be helpful, because in the case of HGPIN, at least focal patchy positivity for basal cell markers will be positive, while in the case of pin-like adenocarcinoma, it will be completely devoid of basal cell marker expression. And MACR is variably expressed, so keep that in mind. You might even get MACR negative cases. In such cases, ERG might be helpful. So in this particular case, where you see towards the edge, you have got this elongated, slightly tufted appearance of stratified columnar looking cells, although at some places there appears to be a vague hint of papillae formation. Pay attention to the fact that this tufting pattern of growth, along with the stratification, pseudo-stratification of these lining columnar cells is present. And as you can appreciate at a higher power, not all of these cells are having prominent nucleoli. In fact, you will have to hunt for the nucleoli in such cases. Probably one or two of them are having prominent nucleoli, but if it were AGPIN would actually have much more prominent nucleolus and in a much wider proportion of cells. This is another case where again you get the kind of tufted pattern of growth of stratified columnar cells, mimicking the tufting pattern of growth of high-grade prostatic intraepithelial neoplasia. See the tufted pattern of growth. Okay, so the various glands, these are all basically malignant glands where the cells are showing pin-like architecture in the form of a tufting and stratification. However, if you were to do a pin-4 cocktail, again, interesting observations. The normal prostatic acini in the middle are highlighted entirely with P63 and HMWCK, not much of expression of MACR, while those glands which look like pin-like glands are actually completely devoid of expression of the basal cell markers and overexpress MACR. The same thing with this particular case as well. You have the normal acini which are highlighted by the basal cell markers, and these pin-like glands are completely devoid of basal cell marker expression and overexpress MACR. Another case, again, with that kind of tufted growth pattern within those dilated acini with pseudostratification of those lining columnar epithelial cells, and on a pin 4 cocktail, complete absence of basal cell markers with overexpression of MACR. Path presenter has one such case which is listed as a pin-like prostatic adenocarcinoma. You can go through that. So you have got a conventional component of prostatic acinar carcinoma by the side, but at the same in the same case, you have got these slightly dilated spaces which are lined by pseudostratified columnar epithelial cells with a tufted pattern of growth at many places. Although at some places there seems to be a vague papillary architecture which raises the issue of a ductal adenocarcinoma as one of the differentials. I've just highlighted this case in order to raise the most important differential diagnostic issue of this particular entity, of this particular subtype, that is a ductal adenocarcinoma. So the most important differential diagnosis of this particular subtype is high-grade prostatic intraepithelial neoplasia, which will show similar kind of a tufting architecture with similar degree of stratification. However, the cells will usually have much more atypical features with prominent nucleolus. And if you do basal cell markers, there will be patchy positivity for basal cells, while in the case of a pin-like carcinoma, there will be complete lack of basal cells staining. Ductal adenocarcinoma, as I've said, if you get within these glands true papillae along with a cribriform or solid mass, you will start thinking more along the lines of a ductal adenocarcinoma rather than a pin-like subtype of Acinar adenocarcinoma. And ductal adenocarcinoma, keep in mind that they can sometimes show patchy positivity for basal cell markers. So that's another important thing that needs to be remembered. Lastly, we shall end this discussion with a little bit of talk about the staging system, that is the PTNM, classification of these prostatic cancers. Again, like for the PGs, I would suggest that don't try learning this entire thing by heart. Rather, try to talk about the various scenarios which lead to upstaging of a prostatic cancer. Thus, for example, if it is organ confined, the stage will be the T category will be PT2. On the other hand, in the worst scenarios, you can actually have extension into the wall of the pelvis or into the bladder, leaving aside the bladder neck, or the levator muscles, rectum, etc., and that qualifies as a T4. And in the T3 category, you have got two subtypes. You have got two categories basically. So if there is an invasion of the seminal vesicle outside the prostate, that is the seminal vesicle, the thick wall, muscular wall of the seminal vesicle outside the prostate, it qualifies as the higher of the T3 categories, that is T3B. On the other hand, if you just have an extension of the prostatic carcinoma outside the prostate in the form of extraprostatic extension or along the neurovascular planes towards the outer aspect of the prostate, or if you have an invasion of the bladder neck, it qualifies as T3A. Coming to the nodal category, you will need to ask one important question. Is the node that is involved, does it belong to the regional lymph node category? That is, does it belong to the external, internal iliacs, or the obturator nodes, or the presacral nodes? In which case, it would qualify as N1 category. Any node involvement outside the true pelvis will basically it will qualify as a distant metastasis. So that will be M1A if it is a non-regional lymph node. B is for bone. So if you have a bone involvement, it will be of M1B category. And any other distant site of involvement outside these sites will basically qualify as M1C. So coming to the various ways of tumor invasion and spread, this I've already talked about when I talked about the TNM staging system. You could have an extraprostatic extension of the prostatic cancer. You could have a seminal vesicle invasion through the muscular wall of the vessel. You could have a direct spread into the urinary bladder or into the pelvic soft tissue or in the rectum, which would basically qualify that particular tumor as a T4 category. You can have spread via the lymphatics to the regional lymph nodes, which would basically qualify the thing as N1, or beyond the true pelvis, which would basically take it one stage higher. And so the nodal disease in the case of the true pelvis will be concentrated in the external iliac, internal iliac, obturator, and the presacral lymph nodes. And if you talk about the N1C category, that is, the M1C category, that is the distant spread, you can have a visceral spread to organs like liver, lungs, and the brain. So that brings us to the end of this discussion. The slides for this lecture have been sourced from Path Presenter and University of Michigan virtual slide box, which unfortunately is now off the grid because they have taken it off the air. So Path Presenter is still around, thankfully. So there's a huge range of prostatic prostatic carcinomas in that site. You can, in your spare time, go through the individual cases and appreciate the myriad histological presentations of prostatic acinar carcinoma. There's quite a wide range of those particular tumors available in that website. Thank you very much.